Hello and welcome to this lecture on therapeutic diets. Now this is a brief lecture, but I just want to introduce you to a couple of topics. And the thing that most people struggle with are all the different names of therapeutic diets. I'm like, what's the difference between an ADA diet and a 2,000 calorie carbohydrate controlled diet? And I'm just going to explain to you a little bit about the different types of therapeutic diets, some tips for maximizing nutrition in a hospital setting, and then assisting with self-feeding problems and challenges. Okay, so let's start out first with maximizing nutrition in a hospital, because a hospital setting is primarily where you're going to see a therapeutic diet order used. Okay, now whether or not that person follows it when they go home, that's a different story. Okay, but some tips for maximizing nutrition in the hospital setting. Okay, because as you know, nutritional status is tied to health outcomes. First and foremost, we want to exercise empathy. Okay, empathizing is to show understanding. Put yourself in your patient's place. Would you want to eat the food at your facility in the manner that it's delivered? Of course, there's been many developments, very positive in most hospital settings regarding food, okay, but not all hospital food is created the same. Motivate your patients. Explain the relationship between their nutritional intake and recovery, health, and disease prevention. They might not understand that those things are linked. Assist them when necessary. Help with menu selection or utilize volunteers who can help complete menus if you have a selected menu in your facility, because these menus are oftentimes confusing to patients, especially if they're not culturally relevant foods. They might not even recognize the foods that are on the menu. Setup. Okay, oftentimes we can help maximize our patients' potential by doing things as simple as opening cartons and straws, positioning the tray. Maximize their potential to actually succeed at mealtime. Check on them. Is the food hot? Is it presentable? Is it correct for the prescribed diet? Observe, does the person tolerate it well? Are they exercising safe swallow principles? What percentage of the food is being consumed? Strategize. Can the family bring in outside food if they don't like the food at the facility? Does the hospital have a select menu where you can help them select for the whole next week the different foods that they like based on their food preferences? And then communicate. Is the PO intake on the decline? Is the patient still hungry after meals? Do they need snacks at different times? Again, can the family be included to help possibly bring food and achieve higher intakes, since in many cases that is associated with better health outcomes? All right, as far as the different therapeutic diets, this is a super busy slide, but I just want to give you some examples, and I won't go through all of them, but of the different types of categories. Now, there's no standardized language for choosing therapeutic diet orders. What one hospital might call a carbohydrate controlled diet, another hospital would call the American Diabetes Association, ADA, and they might give a calorie level, 1,800 or 2,200. To be fair, in an evolving clinical nutrition world, we have moved away from overly prescriptive diets. We know that overly restrictive diets lead to less compliance. Okay, so there's been this movement toward what we call a liberalized diet. So rather than saying you need to eat the American Diabetes Association 1,800 calorie diet, okay, most places have moved away from that. First of all, because there is no proof that they're actually getting that many calories. Okay, and then there's no one-size-fits-all calorie level that works for all adults. Okay, maybe we have smaller portions or larger portions. So you tend to just see it called the diabetic diet, sometimes a carbohydrate controlled, sometimes a consistent carbohydrate. It generally just means not a lot of concentrated sweets. So you would have sugar-free jelly and sugar-free syrup instead of the regular ones. Or it might just not have a dessert and maybe have fresh fruit in place of it. Okay, we use it for conditions like diabetes, pre-diabetes, people with hyperglycemia or COPD. There are also some sodium controlled diets, okay? When there were things on a diet or like a 1 gram sodium diet, anyone in the kitchen and the nutrition department could tell you there's no way you can make food palatable at less than 1,000 milligrams of sodium a day, or it's extremely challenging. Because a lot of times what we say now is the diet is just called no added salt. That might just mean the food is prepared in a regular manner, hopefully not with too much salt, but there's no salt packet on the tray. Okay, and we use that for different types of heart disease and hypertension. A fiber diet, okay, a high fiber diet. Okay, most Americans only eat 12 to 15 grams of fiber a day, but we should be eating somewhere between 25 to 35. So a higher fiber diet would be one that has higher fiber foods on it, preferably greater amounts of whole grains, fruits, and vegetables. You may though, in some limited cases, also see a low fiber diet or low residue, and that might be in preparation for a certain types of GI surgery. Or if they're, pancreatitis, we don't want to irritate the gut at all with a lot of fiber in there. A progression diet, okay, if a person is anticipated to be NPO, so nothing by mouth, they usually then progress to clear liquid into full liquid diet before going on to full texture. And this is for different GI reasons. Again, we're mostly moving away from this progression, or if anything, we do the progression way faster. Used to do 2 to 3 days on clear liquids and 2 to 3 days on full liquids. We know that the quicker we can get someone back to eating a regular textured diet, the better they're going to do. So you might do one meal clear liquid. You did fine, no negative side effects, great. Next meal you're doing full liquids, meal after that you're doing solid textures. A purine restricted diet, you may see that for the case of gout, okay, that's just staying away from foods that contain purines, anchovies, sardines, kidneys, liver, which to be honest, you are not going to find on your typical hospital menu anyway. Kidney disease diet, all sorts of different levels of restriction, sometimes just called the renal diet. Whether or not the person is on dialysis greatly affects how much protein, potassium, phosphorus, sodium the person gets. And we're going to go into much more depth on the different types of kidney disease diet when we look specifically at kidney disease later in the course. As far as a cardiac diet, this can mean anything. Sometimes you hear it called a heart healthy diet or low sodium. It used to be low fat in the 90s and earlier part of the 2000s when we thought that low fat was equated with a heart healthy diet. So you'd have all these junky, low fat, fat-free foods on the tray, which of course is not ideal as well. So a lot of times now the cardiac diet is talking about healthier types of fat and then limiting sodium. And there may be diets for weight gain, which are high in calorie, high in protein, double portions. They might have super high calorie shakes that the kitchen can make. Our immunocompromised patients sometimes get ordered what's called a neutropenic diet, meaning no fresh fruits and vegetables for patients with very advanced cancer and stage AIDS in order to avoid introduction of potentially harmful pathogens from those fresh fruits and vegetables. Okay, and then there's other miscellaneous diets. You might see a kosher diet for religious reasons, or halal, a gluten-free diet, which is very challenging to do in the hospital setting because a true gluten-free kitchen requires a separate kitchen. And most hospitals that I know of do not have two kitchens, one to make gluten-containing foods and one to make gluten-free foods. There are also different types of fluid restriction diet orders that you can order, how many liters of free water the person can have. Again, we'll get more into that when we look specifically at kidney disease, because that tends to be when those diets are ordered. Okay, so I know it's a lot of information. I just wanted to get through kind of quickly to show you the different types of diets that you might see. The goal really, though, in the hospital or in any institutionalized setting is to move towards, again, what's called a liberalized diet policy. You want to throw out as many of the different restrictions as possible. It's easier for everybody involved, and it tends to result in better patient satisfaction with the food. A little bit about self-feeding, because this is kind of tied into, in the hospital setting, who may struggle with eating, okay? Anyone that's had any of the conditions that you see on this page may struggle with self-feeding. And a lot of times we tend to think about it primarily as stroke. We're going to do a separate lecture on dysphagia momentarily, okay? But any of these different conditions can lead to reduced ability to feed oneself, which of course then is tied to lower intakes. Okay, as far as assisting people with self-feeding problems, okay, whether they have the inability to suck, chew, swallow, to grasp, even if they have impaired vision, that can impact intake, okay, and oftentimes our occupational therapists on our teams can help us determine what sort of adaptive apparatus might be helpful in getting the person to suck better, chew better, swallow. And there's things that we can do like using squeeze bottles to push liquids into the mouth. Offer a variety of texture foods if they struggle with chewing. Give cold formulas or frozen bars if they're having difficulty swallowing. Using different modified handled utensils if they have difficulty grasping the different utensils. Or plates with food guards and protective clothing so that they can be more involved in self-feeding without, endangering themselves. Okay, for people with impaired vision, we actually can order a diet called a finger food diet. I've seen that a lot of times, especially in long-term care facilities, where we want to encourage independence, but we need to adapt the diet so that people can eat with their fingers. Okay, this last slide here is just showing you some of the different types of adaptive, assistive feeding mechanisms out there. Things like these weighted utensils. Okay, you can see these, a lot of times places even make their own. Okay, these are very expensive if you buy them individually, but things like suction cups on a plate so they don't move around. Different types of cups with lids. We try to avoid the term sippy cup when we're talking about adults just because it's something we usually use primarily for children. but still everyone calls them sippy cups, but cups with lids, straws. For people with tremors, you can see something like weighted utensils can be helpful. Again, these are all just some ideas. Occupational therapists are much more aware of and can recommend certain adaptive equipment that can make eating easier.